Chapter 7 of ICD-10-CM covers diseases of the eye and adnexa through the code range H00 through H59. There are very few chapter-specific guidelines for this chapter as well. Glaucoma is actually a group of diseases. The most common type is hereditary. Primary open-angle glaucoma is the most common form of glaucoma, affecting about 3 million Americans. It happens when the eye's drainage canals become clogged over time. Angle closure glaucoma is also known as acute glaucoma or narrow angle glaucoma. It is much more rare and is very different from open angle glaucoma in that the eye pressure usually rises very quickly. Secondary glaucoma refers to any case in which another disease causes or contributes to increased eye pressure, resulting in optic nerve damage and vision loss. The guidelines for glaucoma indicate to assign as many codes necessary to identify the type of glaucoma, the affected eye, and the glaucoma stage. The codes are represented from category H40. Patients may suffer from bilateral glaucoma with the same stage and type. In those instances, you would only report the code for the type of glaucoma with the bilateral code and use the 7th character for the stage. If a patient suffers from bilateral glaucoma and both eyes are affected by the same stage and there is not a bilateral choice, report only one code for the type of glaucoma with the appropriate 7th character for the stage. In certain subcategories of the glaucoma codes, laterality is not an option for coding. For example, patient was diagnosed with bilateral primary open-angle glaucoma. Patient was unable to do the visual field test, so the stage was undetermined at this visit. We assign code H40.1134 for primary open-angle glaucoma indeterminate stage. If a patient suffers from bilateral glaucoma but a different stage or type, you would use the code designated for each eye rather than a code for the bilateral condition. So for example, patient presents with bilateral glaucoma, open angle low risk on the left eye and open angle high risk on the right, you would assign 2 codes. One for the open angle high, one for the open angle low, based off of the left and the right. So the left eye would be H40.1222, and then the right eye would be H40.1211. If a patient has bilateral glaucoma with different types and laterality is not an option in the code choice, you would assign 1 code for each type of glaucoma with the appropriate 7th character for the stage. So for example, patient presents with primary open-angle glaucoma, moderate stage in the right, low tension severe stage in the left. And you can see the codes there. If a patient has been admitted with glaucoma and the stage progresses during the admission, you would then assign the code for the highest stage documented. There is a 7th character that is available for glaucomas in which the stage cannot be determined. This is the character 4. It should not be confused with the 7th character 0 for unspecified. Unspecified is used when there's no documentation regarding the stage of the glaucoma. For cataracts, that's a clouding of the line in the ends, and there's several different types, including nuclear, cortical, posterior or anterior subcapsular, Morganian, and traumatic. Chapter 8 in ICD-10 is diseases of the ear and mastoid process. At this time, there's actually no chapter-specific guidelines for these. There is a note at the beginning of the chapter that indicates to use an external cause code, following the code for the ear condition if applicable to identify the cause of the ear condition. The category H60 through H62 contain codes for diseases of the external ear. The conditions in these subcategories include otitis externa, disorders of the pinea, and other conditions. Proper code assignment is contingent upon knowing if the condition is acute or chronic and the laterality of the condition. For example, Mandy was seen today at the pediatrician because her mom noted that since they got back from the pool a couple of days ago, she's been tugging at her left ear, and her mom says that the outer ear appears swollen and red. The doctor diagnosed her with swimmer's ear and prescribed an antibiotic. So the correct code for this case would be H60.332 for swimmer's ear of the left ear. Codes H65 through H75 are codes for diseases of the middle ear and mastoid. The conditions covered include otitis media, perforations of the tympanic membrane, and polyps of the middle ear. The category H80 through H83 house the codes for diseases of the inner ear, including conditions such as otosclerosis, labyrinthitis, and vertigo. In Chapter 9, we have diseases of the circulatory system, categories I00 through I99. If you were around for ICD-9, you may remember we used to have a hypertension table, but there's no longer one in ICD-10. However, there are several guidelines that go around now hypertension coding. The guidelines for hypertension, the classification presumes a causal relationship between hypertension and heart disease, and hypertension and kidney involvement. And those two conditions are linked by the term with in the alphabetic index. So these conditions are actually coded as related, even if the provider does not document them as related. The way they would not be considered related would be if the provider documents clearly that they are not related. So for hypertension and conditions not specifically linked by those relational terms with or associated with or due to in the classification, provider documentation has to link them to code them as related. You would use an additional code from category I50 for heart failure to identify the type of heart failure with those patients that have hypertension and heart failure. If a causal relationship is not stated, you would code those conditions separately. So let's go through some examples. A patient visits his cardiologist for a 3-month follow-up visit. He's being treated by the cardiologist for hypertensive heart disease with benign hypertension. The principal diagnosis code is I11.9, hypertensive heart disease without heart failure. As you can see, it states here hypertensive heart disease, so a cause and effect has been established by the two. The classification presumes a causal relationship also between hypertension and kidney involvement, as the two conditions are linked by the term with in the alphabetic index. These conditions should be coded as related even in the absence of provider documentation explicitly linking them, unless the provider documents something else that is the cause of that and that they're unrelated. If both hypertension and a condition from chronic kidney disease from category N18 are present, you would assign a code from I12, not the I10 hypertension, the I12 hypertension for hypertensive chronic kidney disease. So let's look at this example. A patient with malignant hypertension and stage 5 chronic kidney disease is admitted to critical care. That first listed diagnosis is I12.0 hypertensive chronic kidney disease with stage 5 chronic kidney disease or end-stage renal disease. So that second code is N18.5 for that chronic kidney disease stage 5. According to the guidelines, you also assume a relationship between hypertension and chronic kidney disease when both are stated in the diagnoses. Here, we assume with chronic kidney disease, just as the guidelines allow for heart disease. You have to be very careful when you look at the documentation and how the provider is documenting the diagnosis. For example, patient is admitted to the hospital with acute diastolic heart failure due to hypertension with the end-stage renal disease. Since it is stated due to hypertension for the heart failure, we have our connection for the coding. Our primary diagnosis would be I13.2 for hypertensive heart and renal disease with both heart failure and chronic renal failure. And then our second code would be our code to specify the type of heart failure, our I50.31. And then we use that N18.6 to specify that we have end-stage renal disease. You must pay particular attention to these coding guidelines for these hypertensive conditions, especially in risk adjustment. For hypertensive cerebrovascular disease, you would first assign the appropriate code from category I60 through I60.9 and then the appropriate hypertension code. For hypertensive retinopathy, the code H35.039 for hypertensive retinopathy unspecified should be used with code I-10 for essential hypertension. The sequencing is the reason for the encounter. Secondary hypertension is due to an underlying condition. 2 codes are required here, one to identify the underlying etiology and one from category I-15 to identify the hypertension. Controlled or uncontrolled don't matter anymore in hypertension coding. That's why we no longer have that hypertension table. Without the benign and malignant breakout, we no longer need it. The codes fall in the regular alpha index as all of the others. So the coding is simplified with the code I-10 for essential hypertension. So let's look at this example. Patient visits his internist for his 3-month follow-up visit. He has been treated for hypertension for more than 3 years. The patient's current blood pressure is 160/110. The patient is a current smoker, not dependent. Physician adjusts the patient's medication, reviews their blood pressure readings, counsels the patient regarding smoking cessation, asks the patient to follow up at 2 months, and the documentation indicates benign hypertension without good control. So that's when we just use our I-10 code. I-10 is essential primary hypertension. We would also, in this case, use Z72.0 to capture that tobacco use. There are combination codes for atherosclerotic coronary artery disease and angina. We do not need to use an additional code for angina pectoris when one of the combination codes can be used. If a patient with coronary artery disease is admitted due to an acute myocardial infarction, the myocardial infarction should be sequenced before the coronary artery disease. A causal relationship can be assumed when the patient has both atherosclerosis and angina pectoris, unless the documentation indicates the angina is due to something other than the atherosclerosis. When coding for intraoperative and post-procedural cerebrovascular accident, proper code assignment depends on whether it was an infarction or hemorrhage and whether it occurred intraoperatively or postoperatively. Category I-69 is used to indicate conditions classifiable to categories I-60 through I-67 as the cause of late effects themselves classified elsewhere. The codes from category I-69 may be used on a healthcare record with codes from I-60 through I-67 if the patient has a current cerebrovascular accident and deficits from an old one. You would assign the code Z86.73 for patients with a personal history of a TIA and infarction without residual deficits as an additional code for the history of cerebrovascular disease when there are not neurologic deficits present. Myocardial infarctions or heart attacks occur when the blood flow to the heart is blocked, and there are 5 classifications of myocardial infarctions. The codes for acute myocardial infarction identify the site, such as anterolateral wall or true posterior wall. The subcategories I21 through 0 through I21.3 are used for ST elevation myocardial infarctions or STEMIs. Subcategories I21.0 through I21.2 are site-specific, and subcategory I21.3 is coded when the documentation does not identify the site of the infarction. Code I21.4 is for a NSTEMI and non-transmural myocardial infarctions. There is no classification for acute or chronic terminology. Instead, it's just classified as initial or subsequent. When the patient requires continued care for myocardial infarctions, codes from category I21 may continue to be reported for the duration of 4 weeks or less from onset. For any encounters after that 4-week time frame, if the patient still requires continued care related to the myocardial infarction, the appropriate after code care should be assigned rather than that code from that I21.2. For encounters occurring while the myocardial infarction is equal to or less than 4 weeks old, including transfers to other settings, the myocardial infarction meets that definition for other diagnoses. Codes from category I-21 may continue to be reported. Otherwise, the code I-25.2, which is old myocardial infarction, may be assigned for the old or healed myocardial infarction that doesn't require further care. The code I-21.3, or STEMI myocardial infarction of unspecified site, is the default code for the unspecified term of acute myocardial infarction. If an acute myocardial infarction is documented as non-transmural or subendocardial, but the site is provided in the documentation, it is still coded as the subendocardial AMI. The subsequent rule is that if a patient has an AMI and within that 4-week period of the initial has suffered another myocardial infarction, then it's considered subsequent. And we would then look at category I-22 for those codes. For example, patient was admitted to the hospital suffering from an acute myocardial infarction of the inferior wall. The patient was released 3 weeks after suffering an acute MI of the left anterior descending coronary artery. The first listed diagnosis is I-22.1, subsequent ST elevation myocardial infarction of inferior wall. And the second listed diagnosis, I-21.02, ST elevation myocardial infarction involving left anterior descending coronary artery. Hypertensive crisis is a severe increase in blood pressure. Hypertensive crisis can be classified as urgent or emergency. An urgent hypertensive crisis is when the patient's blood pressure is extremely high, but it is not suspected to have damaged any organs. An emergency hypertensive crisis is when the patient's blood pressure is extremely high and it has caused damage to organs. A code from category I-16 is assigned for hypertensive crisis. Chapter 10 of ICD-10 contains diseases for respiratory system, and that ranges J00 through J99. This chapter includes codes for upper respiratory infections, pneumonias, lower and upper respiratory tract infections, lung diseases, and other diseases of the respiratory system as well. COPD, or chronic obstructive pulmonary disease, is a kind of an umbrella term used to describe progressive lung diseases, including emphysema, chronic bronchitis, refractory asthma, and some forms of bronchiectasis. The disease is characterized by increasing breathlessness. COPD is often a mix of chronic bronchitis and emphysema and gets worse over time. Conditions found in categories for COPD include asthma with COPD and chronic conditions. Let's review an example. Patient with COPD is admitted by her internist with a diagnosis of COPD with viral pneumonia. The first listed diagnosis is J44.0, chronic obstructive pulmonary disease with an acute lower respiratory infection. And then that secondary diagnosis would be that J12.1 for the pneumonia classification. Asthma is a chronic lung disease in which the airways narrow and swell and produce extra mucus. It affects more than 25 million Americans. Asthma symptoms include coughing, wheezing, shortness of breath, and chest tightness. Asthma can't be cured, but it can be kind of treated and managed and controlled. Coding for asthma has greatly expanded in ICD-10 versus our old I-9 system, and includes the severity of intermittent and persistent, and then gives choices between mild, moderate, and severe types of asthma. You can look at this chart and it'll kind of help identify different types of severity of asthma, and this was produced by the National Heart, Lung, and Blood Institute. Codes and categories J44 and J45 distinguish between uncomplicated cases, those that have acute exacerbation. Code J96.0 is acute respiratory failure, or code J96.2 is acute and chronic respiratory failure, and they may be assigned as a principal diagnosis when it is the condition that's responsible for that admission to the hospital. And you assign the appropriate fifth digit to indicate if hypoxia or hypercapnia is present. Respiratory failure may be listed as a secondary diagnosis if it occurs after admission or even when it's present on admission but doesn't meet the definition of principal diagnosis. When a patient is admitted with respiratory failure and another acute condition, the principal diagnosis will not be the same for every situation. It depends on the documentation and the circumstances of that admission. Guidelines indicate to only code confirmed cases of influenza due to certain identified influenza viruses from category J09. In this context, confirmation does not require specific documentation of a positive lab test. That coding is just based on that provider's clinical documentation, their diagnostic statement saying that the provider has influenza. Code J95.851, ventilator-associated pneumonia, should only be assigned when the provider has documented ventilator-associated pneumonia. You also use an additional code to identify the organism, but you would not use an additional code from categories J12 through J18 to identify the type of pneumonia. Chapter 11 are diseases of the digestive system, and this is another one where we don't currently have a lot of chapter-specific guidelines. So this code range is K00 through K95. Esophagus, stomach, and duodenum. There are certain codes in the subcategory for esophagus and stomach and duodenum that require the use of an additional code to identify alcohol use or abuse or dependence, and that's required to be documented to meet that level of specificity. The codes in the subcategory list hiatus hernia as an excludes 2, which means it can be coded if both conditions are documented and if both of them exist. For the appendix, this subcategory includes acquired, congenital, and recurrent hernias. Hernias with both gangrene and obstruction is classified to hernia with gangrene. Enteritis and colitis. One of the largest expansions in the coding of the digestive system has been codes for Crohn's disease. Code selections include the specificity of the site, such as small or large intestine, as well as any complications or manifestations, such as bleeding, fistula, obstruction, or abscess. These complications and manifestations are identified with the use of combination codes. Let's take a look at an example. So here, Tim is being seen in treatment today due to vomiting with traces of blood. He has been a longtime alcoholic with recent binge drinking, and after an endoscopy, the surgeon notes he has Barrett's ulcer with hemorrhage exacerbated by his alcohol dependence. The principal diagnosis is going to be K22.11 for ulcer of esophagus with bleeding, and then secondary we use code F10.20, which is alcohol dependence without complication. The codes found in the range K35 through K38 are for appendicitis and other disease of the appendix. In order to assign a code for these conditions, you need to know if the acute appendicitis is with or without peritonitis. Acute appendicitis is a common and serious condition that requires immediate surgery for treatment. A hernia occurs when the contents of the body cavity bulge out of the area where they are normally contained. These contents, usually portions of the intestines or abdominal fatty tissue, are enclosed in the thin membrane that naturally lines that cavity. So for example, in this case, we have Jennifer. She's been diagnosed with an incisional hernia without obstruction or gangrene. The proper code assignment in this case would be K43.2 for incisional hernia without obstruction or gangrene. Our code range K50 through K52 are our non-infective enteritis and colitis, and they do contain those codes for Crohn's disease that we discussed earlier.